Hello, everyone, and welcome to today's APS webinar entitled Cardiopulmonary Exercise Tests Using Wireless Sensors, presented in partnership with VO2 Master. My name is Jacob White with the American Physiological Society, and I will be serving as your moderator today. In today's session, Jeroen Molinger will discuss using wireless sensor technology to conduct cardiopulmonary exercise tests and how it may be used to enhance field tests and provide sufficient information on cardiopulmonary health. Now, before we begin, we just have a few housekeeping notes. Out of respect for our speakers, we ask that you refrain from photo or video captures of the presentations in whole or in part. This session will be recorded and available for future viewing through a link on the registration webpage. Recording or taking photographs of another person's presentation without their explicit permission is prohibited. Now, at this time, all attendees, except for the speaker, are in listen-only mode with video off. We are happy to answer any questions that you may have, as long as they're entered through the Q&A function on the bottom of your screen at the end of the session. I'd also like to take this time to thank our partners at VO2 Master for their support of APS's 2024 Integrated Physiology of Exercise webinar and their general support of our exercise physiology and applied physiology community. Now, before we begin, we would like for you to answer a quick poll regarding your technology and research experience. I'm going to launch the poll now. Please just take a brief moment to answer the questions, and then we will begin our program. Thank you. All right. Thank you so much for taking the time to answer our poll. Now it is my pleasure to introduce our speaker, Jeroen Molinger. Jeroen is a clinical exercise physiologist specializing in metabolic heart assessments, metabolic muscle imaging, and clinical exercise physiology, particularly in the perioperative and heart failure space. He is the research program director and lead clinical medical exercise physiologist of Duke University's Human Physiology and Pharmacology Lab and the Duke Heart Cath Lab. Now, onto our program. Thank you for joining us, Dr. Molinger. Please begin whenever you're ready.
Can I set my, yep. Here you go. Perfect. You can see my screen right now?
Yep, you're good to go.
Perfect. Thanks, Jacob, for your nice introduction. So kind of a short introduction of myself again. My name is Jeroen Molinger, senior clinical medical exercise physiologist here at Duke, working at those specific labs. And kind of my take from this specific webinar will be, apart from only not using wireless sensors, but also kind of introducing CPET 2.0, right? So when I was coming here at Duke, is that my kind of focus on my research was everything in regard to cardiorespiratory fitness, CRF, V2 max, V2 peak. And I think first, when we have this specific kind of metric specifically being aligned and specifically being talked about, I think it's essential to kind of have a kind of fundamental explanation of what CRF truly means. We know, of course, it is a very high predictor of health, longevity, and also risk. And the reason why I think it's such a powerful biomarker, because it is such a integrated biomarker, not a single organ biomarker, where we have the ability to couple the lungs, the heart, and the muscle to specifically see which specific system is more or less limited, which defines in higher or lower CRF. Kind of going to the the history and the science of what CREF truly means and what kind of potential predictor it can be. I think one of the big names in the CRF world regarding prediction set is Kodama in 2009 in JAMA, and showed already that this is a all-cause quantitative predictor, a very robust predictor of all-cause mortality and cardiovascular events, which specifically also what they saw with you have the ability to increase your VO2 max, your CRF, with one metabolic equivalence of a task, you will have an ability to decrease your overall mortality between 13 and 15%. And again, also Clausen here did a very, I think, a very nice kind of a follow-up, showing that even in a 46-year-old follow-up in those specific data set, you can see profound changes during your life cycle and also during when people get older. One of my, I think, still one of the most powerful articles out there right now, and I definitely advise you to read this one, is from Mensaker. This is also the data set that we currently use in our platform, is that they kind of grouped a huge amount of data from 122,000 people and kind of created a low, below average, above average, high, and elite population. And what they really saw was, even if you have the ability to change your specific CRF from one group, for instance, to low to below average, you really have a very powerful outcome in regard to changing your, decreasing your overall mortality. As you can see here, if you just go from low to below average, you still have a 95% of decrease of your overall mortality. What is kind of interesting when you're looking at this classification, and also for everyone else here, more or less also in the clinic and maybe potentially in the perioperative space, is that currently we kind of find that the 4-MET rule is kind of the rule where people below the 4 METs is a kind of a threshold of risk. As you can see here in this large group, there is almost no 4 METs, right? It's the lowest group is almost double the 4 METs as defined being low. So you can even ask yourself, is that 4 METs a true threshold that we need to go by, or we need to have a more granular insight in what METs and risk really means? Going a little bit back to the surgical risk and also what CRF really tells us, I think it's kind of a no-brainer, but I think everyone already knows from their own potential clinical experience. Eyeballing a patient is not a way to go. We see that a subjective assessment of someone, or even does not give you the full insight in their specific CRF, is not a way of guessing, it is a way of an assessing, right? So, and that's the same way if you're looking at specific outcomes of CRF, where, for instance, discharge people with a low CRF after they had a procedure. And we saw that there's a defined correlation between the readmission risk and that specific CRF number they had at discharge. Kind of for me also going into the way how we would see, or how do we potentially discharge patients from the floor. Currently, there is no real defined biomarker, and I think CRF potentially, in the way how we approach it, could potentially be a biomarker that can be used as a kind of a biomarker for discharge. Okay, how can we currently assess VO2 max CRF? We have right now, I think, 3 ways of doing that: through the questionnaire, and there's a lot of data already here, also from smartwatches like the Apples, the Garmins, and the Fitbits, and of course our golden standard, the CPET. The CPET, of course, is still there. I think it's a very vital instrument to assess CRF. Only it is bulky, it is expensive, and I think by far the biggest issue with the CPET as we do it as of now is it's not scalable. That's 1 hour plus, including all the reporting potentially 2 hours plus, that does not make it scalable at all in a large healthcare system. So let's a little bit go to the questionnaire. The DASI score is a score that we use in the US very predominantly, and I think this already shows that Widow et al. Did a kind of a nice, kind of a small article in showing that DASI-derived fitness measures really overestimate METs and VO2 max numbers. They are very much correlated to each other, but they overestimate. And essentially what happens then, if you really ask people a question like, can you walk up a stair with groceries? And people say yes, that really does not give you the full insight if people really can do that. And if you overestimate someone based on the questionnaire, you get patients in on a surgical procedure who are potentially high risk, and you have no specific insight in their risk status, and also did not have the ability to potentially optimize them before their procedure. So my kind of advocate on this when I came here at Duke, we did a lot of exercise testing, CPETs in the Netherlands. Me thinking, being naive at Duke, I want to do more CPETs, but then we found out it was completely non-scalable. So 4 or 5 years ago, I thought, can we kind of create a, call it a point of care assessment, a point of care CPET, something that you do on the bedside in a time frame of 12 minutes, have the ability to have a direct reporting on your hands, and also have the ability to do that in any given place. So not the need for specific hardware like treadmills or bicycles. So we came up with here at Duke with a new platform that's called Splendo. And Splendo is a kind of platform that kind of derives or connects different sensors to really kind of sync them and have the ability to do on-the-fly data control on the raw data coming in, and also have the ability to do an instant reporting based on the data set itself. So kind of going through what our current kind of data, how current sensor stack looks like. As you can see here, we have, of course, the VO2 test, the metabolic card. We have some specific heart rate sensors, the polars. We have myozone. We work on other potential heart rate sensors here. We have the vital stream from Caretaker. That's a beat by beat systolic, diastolic, but also stroke volume and cardiac output SVR measurement based on a small cuff on the finger. And as you can see also, we have NIRS devices, near infrared spectroscopy. So what we're kind of doing is kind of creating an overall kind of a sensor stack that really defines the physiology of the patient during a specific time, doing the specific test, and also instantly kind of going through that in our portal with the use of an app, and have that data instantly being in front of you and instantly being visualized easily in a report. So kind of how does it work? How do we do this? So currently we have a lot of modalities that we can test with, right? We have our old school RAMP protocol, YMCA, modified MCA. We kind of created 2, I think, protocols that can be used very well, and also validated them here inside Duke. One of the is, and we'll talk a little bit later on in the slide deck, what the 1 minute allowed test on the air bike and the 6-minute incremental step test. As you can see here, we have those specific sensors in place, and kind of what we were doing here is everyone is aware of the Fick equation, and the Fick equation kind of tells you specifically if there are or where there are specific limitations of this patient. So of course the VO2 we can assess that with a metabolic card, cardiac output potentially with the vital screen, but also with some specifics on the polar device. And I will go a little bit further on in depth in what the NIRS can potentially tell you as a proxy of your oxygen AV-diff. Oxygen AV-diff is a kind of an extraction ratio when you're measuring with a true direct Fick, what we do here in the cath lab. We're measuring the oxygen content from the A-line compared to the oxygen content from a PA catheter and mixed venous, and really show how much extraction was the body able to do, and it kind of creates an insight in where potential limitations will be. And of course, when you do this test, you have all the sensors there, and it will be a kind of creating an actionable report that you can use, not only looking at specifically at your VO2 max or VO2 peak, but also specifically which specific systems were limited on this patient or client. Go through that, one of the things that I wanted to do is to make sure that this specific assessment can be done with anyone. So you don't have to have a very high sight or knowledge or skill set on physiology to be using this specific modality. So we created an app in our a specific app. It's called Splendor Monitor, and the Splendor Monitor integrates all the specific sensors, but that steps to connect with other sensors is very easy to go by. Kind of going through, this is for instance a 6-minute walk test when you have X amount of sensors, you can have another sensors also being allocated, but kind of going through the setup process, going through the specific calibration of the VO2 master. And it's all done in a very easy flow, which anyone can be trained in 30 minutes or so. Okay, our 6 missed. So one of the questions I had here is I wanted to do a test in a clinic that can be used by anyone, any place, anywhere. So if you don't have the resources or potentially the financial funding to have a bike or a treadmill, can still use another modality to have still a ramping up fashion of a modality of testing, but with the use of wireless sensors, and can do that in any place, anytime, in any clinic. So one of the things that we did was looking at our old school method, right, and comparing that with our new school method. The new school method is then defined as the 6-minute incremental step test. So what is the protocol and how do you do it? It's literally kind of marching on the place, and the marching on the place is the only thing that you can change based on the speed of marching. So you'll be staying here, you have your knees up and down. We have a metronome in our app that kind of defines specific the speed of that of the pace, and you're literally following the metronome all the way up doing that 6 minutes. The only change is how is the start pace. So we have the 30, the 50, or the 70 beats per minute, and that kind of defines where you're at based on your own level. For instance, what we see in our validation that we did in our heart failure population, everyone started with 30 and we increased by 10 every 30 seconds. 10 or 5, it depends, and anyone else was going by the 50, and the 70 is more or less only for athletes who had definitely a VO2 higher than 30, 35. So the visibility of a novel augmented 6-minute incremental step test. And what we did was I wanted to make sure that this is a test that is being safe, that we can do also in a very sensitive population like heart failure patients. So we used our population in our cath lab. We did a full-blown invasive exercise test in the cath lab in the morning, and that's, you can see the kind of the setup in A. And 3 or 4 hours later on in the recovery room, we did a full 6-minute incremental step test, and then we showed if there is a correlation between the metrics of VO2 kinetics from the A setting to the B setting. And we saw there was a intriguing, I think, even in this very well-defined, deconditioned population, we saw an intriguing correlation here, which kind of always makes the case that you can even use this specific metric as a follow-up tool. And I think it's not a specific metric that kind of takes away the whole CPET, but if you really want to kind of work into the physiology, not only looking at steps of distance like a 6-minute walk, you can use this very well in this very sensitive population. And again, we did not have any adverse effects during the test. Everyone was able to get through that full 6 minutes without any issues. So next step was, okay, now we did our clinical population. Let's make it more bigger and see if we can do a healthy volunteer study to compare the full CPET on the bike against the 6-minute walk test against the 6 missed. So then we saw in how does the 6-minute walk compare to the VO2 max test, RAM test on the bike, and how does the 6 missed test compare with the VO2 max test on the bike itself. I think he was all kind of intriguing kind of data here, so kind of making the case that the VO2 kinetics on the 6-minute walk were definitely not that high correlated with the VO2 max that we saw on the air bike. We know, of course, that there's a more ramping up fashion where the 6-minute walk is a more kind of a steady state kind of approach. What was more interesting that we saw a very high R squared of 0.75 in our healthy volunteer group when we compared the 6 missed with the VO2 master against the exercise test on the bike. Next version was then we did all the validation in our clinical population, in our population of healthy volunteers, to kind of creating a framework of how this specific modality with those sensors can be used in a very valid fashion. And our last step will be, we need to kind of also validate the VO2 master as a device itself. So this is a setup that we used as the vacuum mat with a mass flow. So we can kind of creating specific flows with tidal volumes, frequencies, and also specific VO2s, which we can set in and then see how the VO2 master kind of correlates with the specific number that we kind of put in the metabolic simulator, and to see how the VO2 master did. This data not yet published. We are in the middle of the article itself. We will publish I think in 1 or 2 months or so. And this kind of what we saw. I think we saw a very well-defined high R squared for the VO2 and also for the VE. Same for the tidal volumes and the frequency. But I think what's interesting enough that the error margin overall was below 2%. And that's very, very good for a metabolic simulator, even as it is a full card. So I think it proves that the technology that we use in this kind of metabolic wireless kind of framework works very well and gives you very high valid numbers. Okay, so when you see how you can see ref being used in the clinical environment, I think we wanted to go a step further. Can we kind of decentralize CPETs? Do we have the ability not only having patients coming to the clinics or the hospitals to do that CRFs, but also potentially can you do that at home when you give those patients those sensors, then they can do a bi-weekly, weekly assessment. One of the things that we're kind of setting up here with Duke, and then we are almost there, to not only looking at the change on a whole year of patients with heart failure, to see does that VO2 number itself, how does it kind of fluctuate through the year? And what specific limitations do we see on those patients? And if those numbers are there, can we have a more profound insight in decompensation and escalation of this patient based on the numbers that we see in the kind of home-based fashion? So we created also an app that can be used at home, where we have all the numbers also here. And you can see a kind of an outcome, a dash of when you see the specific metrics being used in an app, this Pendo Fit, one of our apps that we use for our home-based research. And people can do the full 6 mist or a sub-maximal 6 mist to have a better understanding in how their specific metrics change, and also have the ability to change interventions based on the specific that we see regarding, is there a specific ventilation limitation, is there a specific augmentation of stroke volume, a more cardiac central or a muscle peripheral limitation. Okay, the reporting. So what we kind of have, this kind of a kind of a fast how our full report looks like. So what we do here is, you can see here also, of course, you have kind of history in what you did based on your maximum ventilation. You can see here the low, mid, and high. That means the low, the mid and above, that's 20% of breathing reserve. This is definitely lower than 50. So you can see here, so definitely lower than 70. There's definitely a lower margin or a lower number of the predicted maximum ventilation. Same here for the VO2 max. As you can see here, we also put someone in a specific percentile based on the Mensaker paper to see also how or what specific will change in regard to your overall mortality when you go from above average, for instance, to high. Same goes for the VO2. You can see here the full set of the 6 mist. Always intriguing that you can see here a very nice plateau of the VO2, showing that you have a true VO2 max here. Same when you're looking at the specific kinetics of overall minute ventilation, where you can see the tidal volume versus the frequency. The orange is the frequency and the purple is the tidal volume. Same goes for the O2 pulse, which you can see here very well. Interesting enough, you can see there was a kind of plateau with the last piece. You can see a change in upright change. I think it's, when you look at that more closely, I think then the need, I think, for a NIRS device comes very apparent. So what we use, and that's kind of what we also saw in our cath lab procedure, where we do the direct fix. So we do the true measurements of a line versus Swan cath or mixed venous measurements that we saw in the first piece. You can see there is almost a plateau on the augmentation of stroke volume, and then you can see a small decrease and again a small plateauing again on the O2 pulse. This itself does not give you a different client or definite reason that this should be a augmentation dysfunction. The only reason to do that, if you're looking at VO2 derived by heart rates, that from a Fick equation, VO2 divided by heart rate is your stroke volume multiplied by your oxygen AV diff. So a little bit depends if that fraction of the slope is both there. So you can see here, if you're looking at the extraction ratio or the extraction slope on the muscle, the nearest muscle signal, you can see here there's definitely a extraction occurring throughout the test with a more steeper slope at the end, which is also being seen over here. The reason why we see an extraction, and you can already see that the specific change that we see here, mainly the complete plateauing here, is fully done by the inability to augment stroke volume at the specific patient. So kind of a oversight of the results. You can see all the specific capacities that we can measure. I think that's kind of people already know. Going from the clinical more to the performance perspective, our lab, the Duke Cardiovascular Performance and Innovation Lab, also has a formal collaboration with Duke Athletics. So we do a lot of D1 team assessments, the Duke soccer, the basketball. So what you see here are, for instance, 3 ladies from the Duke soccer team do an all-out test on the air bike. And what we did was, what we saw, when you do this specific test, it's kind of I would call it kind of a quick and dirty measurements of VO2 max, VO2 peak. We also did validations against just a REM protocol on the bike, and we saw a very well-defined correlation that is also coming up in an article very soon. The most benefit from this specific assessment is it is so short. So what we did here within Duke with a team of 38 or so, 28, we are able, when we have 3 systems in running, you can do around, we did around 30 athletes in 2.5 hours with full reporting. So it's a very easy assessment when you still have the ability to have the full data set of VO2 max, VO2 peak, and also have the ability to really dissect specifically if there are the specific limitations from the breathing perspective, dysfunctional breathing, ventilation limited from a tidal volume frequency kind of mismatch, all the way up to cardiac output stroke volume augmentation and peripheral muscle mitochondrial respiration. So some shots of the report itself. I wanted to kind of show that we also have, of course, the bike integrated. As you can see here in the in the green line, that is the wattage line of the 1 minute allowed. Thank you. That's it.
Thank you so much for the great presentation, Jeroen. And just a reminder, if you have any questions, please submit them in the Q&A function at the bottom of your screen, and then we will take them accordingly. And just a heads up, we do have quite a few attendees here today. So if we cannot get to your question, I do apologize. Do you need a longer warming up for patients after HTX for a reliable result for the 6 mist?
No, because if you kind of in the same way, if you're looking at 1 minute allowed, if you're kind of dissecting the time where the true magic happens, right? It's kind of in the middle. So the first 3 minutes of the 6 mist is kind of an easy going. There are no issues there. The potential last 2 minutes or so is there when you see the specific kinetics really being able to augment. And that's the same thing for the 1 minute allowed. The first 30 seconds are kind of easiest, but the last 30 seconds is where it's the hardest. And then you can see the specific numbers really significantly increase, and you can see the specific limitations very well being dashed. Yeah.
Thank you. And the next question is actually a 2-parter. Do you use the 6 mist on the ICU, and how do you measure the beats?
Oh, good question. So yeah, we do it definitely in the ICU. The metronome itself is in the app. So the app itself gives you the specific, I think that you're meaning with the beats, right? And that's in the app itself, and you're measuring the beats from the heart. We still have, we can have we have sensors on the chest, potentially, if you can do that. We have light sensors from Polar that you can do on the underarm. So there's a lot of way of measuring also heart rate in the specific patients.
And so a question that accompanies that is, because patients who are able to stand cannot perform it that fast, do you use a calibrated bed cycle in the ICU?
Yeah, also good point. We are just starting using it right now. We haven't done it yet. It's one of the things that I want to see if a step protocol or a block protocol, or maybe even a small ramp, can be utilized in our ICU. Currently, we are only doing it in a very small cohort in one of our studies. But I think it's a very interesting modality when you really want to kind of make sure that the effort is really well maintained and be controlled, which you only can do with the bike, definitely.
Thank you. And have you contemplated blending your incremental step test with a classic 6 MWT? That is a 6 MWT with an increase in cadence every minute.
Yeah, good point. Good point. Yeah, it will be. The thing is, if you really want to do that, it becomes almost kind of a shuttle beep test, right? When you're kind of increasing that specific pace, which is already there, people use it also, a modified shuttle run, shuttle walk test. And again, the reason why I did that in a step fashion is that if you want to put someone in a framework that they need to kind of move around, that takes away the easiness of the modality. I want to have the patient being in a small office and still being able to do this test.
Appreciate that. How did the decision-making test work out, and how can it be used in the home with heart failure patients, clients?
Right. I think you mean then the home-based assessment, I think he's going
Yes.
from. Okay, cool. Yeah, so there's always kind of the issue here with you need to go max on a patient at home, right? And I think that's not always the case. And I think even on the way around, I think it's not even needed. I think when you have the ability to have a kind of a submaximal step test, we're looking at a potential step test of 3 or 4 minutes or so. Looking at the slopes, what we're measuring are by far also very much predictable. And combining those metrics when you have the NIRS in place, looking at specific derivatives of the O2 pulse, combining those, and also have the ability to see specific vehicle mismatching, that in itself is already occurring from the get-go during a test itself. So that's the thing where we're currently into, to see, we do some piloting and to see what specific modality works best. And other people are able to do that very easily and safely, right? So as of now, still anecdotal. I don't see, we have not seen any issues there. I think it is a very feasible way of doing tests. And also, I think when we need to go, the kind of decentralizing optimization, you can also now do optimization at home instead of doing the old school approach in the rehab center.
Thank you for that answer. And a question about NIRS. The submitter says, I noticed in your presentation you used the red NIRS device. If I am not mistaken, I thought the red NIRS device was designed for skeletal muscle. What was your experience like using the red NIRS device for cerebral blood flow instead of a functional NIRS system?
Yeah, I think very simple. There are, secondly, it's already integrated in our system itself. This is also an easy add-on. We don't have to do any engineering work to get the specific done. And it's a very cheap option. There is already some validation done looking at specific functional systems against the turn red device itself. And again, it's anecdotal, we have not published it yet, but we see also a very high correlation between those specific metrics. And again, it's a very inexpensive or a relatively inexpensive sensor to be used. And that sensor can be used also from the muscle itself. So it's from a cost perspective approach, a very easy way for us to do this.
Thank you. Now, is there any specific CPET protocol available for the geriatric population?
Yeah, I would even go for the 6 mist because we did it in patients. I think my oldest patient was 89. Went just well. It's a very easy way. It is safe. And also the reason why we didn't tell you, but also the reason why we did the step instead of the stepper is to make sure there's also safety there regarding the risk of fall. So it's a very easy way of assessing a patient in a very well-defined, controlled fashion without having the risk of falling.
Thank you. And next question is, have you used NIRS devices to measure cost of breathing in accessory respiratory muscles?
Yeah, also a good point. Yes, we do, and we're still doing that specifically and looking at, we already saw that dysfunctional breathing in my slide is, we do ultrasound guided location of the NIRS device in intercostal. There are also even potential ways of doing it for the diaphragm. It depends how you kind of locate that specific sensor. But we definitely see a correlation between dysfunctional breathing, where you do a more chest breathe or having a very high frequency, if you're looking at specific intercostal muscle recruitment, and therefore also a higher cost of or a higher muscle saturation at that specific time frame. What we see right now is it's kind of an intriguing way of also educate people in how to breathe, looking at a specific measurement, doing an intervention or a training. Yeah, but there's definitely a interesting correlation there. Yeah.
Thank you. And the next question is actually a two-parter. Please, could you elaborate on the 1-minute test for performance athletes? Is it the time when the muscle is using predominantly anaerobic metabolism? Apologies, this is a three-parter. How do you estimate VO2 max from it?
Cool. Yeah, no, good point. So when I was kind of doing this at the beginning, I was not thinking that we should not see any potential plateauing on a VO2 during a 1 minute allowed, because that doesn't make sense from a perspective of energy systems. But we also know that the energy systems do not work as a graduate way. It's not a gearing up of energy. It's every single system is on the run from the get-go when you're doing a 1 minute allowed. That means that, yeah, you're predominantly anaerobic from the last potential, let's say 20 seconds or so, but that gives a huge amount of stress to the system itself. And that we did see a true plateauing in the last 20 seconds of the test with the VO2, even on the ventilation. And we did see, a little bit depends on where you are limited, yes or no, people who are even plateauing on the saturation of the muscle. They maintain the specific extraction, or people who have a peak in extraction and then deteriorate during the test itself. So have the inability to extract during the specific last, let's say 30, 20 seconds or so. So the derivative of the sensor stuff is completely the same when you're doing a old school ramp, only it is a much condensed way of looking at the data. And I think the most profound, mechanism where it works so well, because it's the air bike. It's such a high recruitment, very fast recruitment of your lower extremities, your high extremities, and also your trunk in such a high fashion. There's a huge amount of demand there. And you somehow need to kind of redefine that demand during that 1 minute. And anyone who has done it, it's horrible and it stays horrible. You cannot train for it, and it always maintains a very sensitive marker.
Thank you. Now, what is your opinion about the possibility to identify central versus peripheral limitations of exercise-induced fatigue?
Right. I think we can do that very well. Not only in the old school way of only looking at VO2 and VC2 data. You always need to have, and at least I would say 2, or let's say minimum 1, of course, but maybe 1 or 2, maybe 3 near sensors to have the ability to really see how those specific numbers change, and if someone is decompensating on one side to another side. And it's kind of looking at the Fick equation itself, where you can see, and again, we saw that there's a good correlation between our oxygen AV diff directly measured in the cath lab versus our versus our desaturation curve, or we call it our critical metabolic rate curve, what you saw in our reporting. That we kind of showing is that the kind of the kinetics of the near signal itself correlated very well with the steep and with the slope of the deoxygenation and extraction ratio on the oxygen AV diff using the A line versus the SWAN mixed venous measurements, mixed samples. So I think, yes, we can do it very easily. Only it is a different way of looking at your data. When near signals comes into play, there's a different look at data. And I think NEARS is essential when you really want to have a profound insight in central versus peripheral. O2 pulse combined with the critical metabolic rate, I think is essential to have that discussion and see what specifically is limited.
Thank you for that. Next question is, do you see this being used in an outpatient cardiac rehab setting for exercise prescription purposes?
Absolutely. I think that's even the way that we even need to go by. I think there was also kind of also my way of doing this specific, of creating this specific platform is we need to kind of decentralize these kind of assessments, but also interventions. And I think even we need to go even beyond that. I think even an intervention or training home-based or in the clinic, that in itself is already an assessment, right? So you can see how people respond to a training more significantly and have an ability to kind of tailor those response to the change of your volume, intensity, or any modality what you want to do. Do you want to go for the more profoundly sprint interval trainings or a hit like the 4x4s, or want to go by a zone 2, all regarding the aerobic capacity changes. That kind of gives you kind of tools and really tailor that specifically to your patient or client. Yeah.
No, thank you. And the next question is a bit expansive. So if you wanted to take some time to think about it or go to another one, please let me know. It's how do you propose doing this similar protocol for an anaerobic sport rather than just aerobic endurance ones?
Yeah, good point. So the reason why I think the reason is a very good question, because exactly the reason why I do the women in the louds in our basketball and our soccer players, because it doesn't make sense for me at all. And I did it a lot also in the Netherlands, in our Premier League and in our own soccer players, to do a treadmill test when they are ramping up the speed and the gradient in a time frame of 12 or 50 minutes, where they will never ever run for 12 or 50 minutes doing a match. So if you really want to, I think, have a better understanding how V2 kinetics work, kind of creating a modality that kind of simulates what they do. It is sprints and recovery, sprints and recovery. And that's the same thing with the woman in the loud. You're kind of creating an overall sprint where you, of course, have a very well-defined depletion of your glycogen stores and all that stuff. And I think that's the reason why it's so predictive in those specific team sports. Apart from the benefit, of course, a shorter time and easy understanding and have an instant report there, we're already creating it to see if those specific percentiles. So how would you kind of define a percent over D1 athlete? I'm not the one that's going to say that you need to have that a high VO2 max on a D1 basketball player makes a good player. I would say that a D1 basketball player should have a fundamental aerobic capacity to be able to maintain a performance throughout the game. So it's kind of creating a good fundamental kind of piece where you can build on to be better, regardless of the sprints and stuff.
This is actually a question on the same vein there. It's generally believed that tests lasting approximately 1 to 2 minutes at maximum effort are considered anaerobic in nature. Additionally, to measure VO2 max, exercise durations typically fall within the range of 6 to 16 minutes. Could you elaborate on how a 1 minute test can provide valid VO2 max data?
Good point. I think what's going to happen right now, because it's all about the time demand curve. Based on the air bike, I think this is not being feasible when you do a wind allowed on just a bike itself or a treadmill. That's not going to work. It's all about the all effort and recruitment of so much muscle in such a short period of time that makes kind of the modality so valid. So what's going to happen? It doesn't matter if you're anaerobically in the end. You're going to stress out your aerobic system. The aerobic system, of course, is slow, has a delay, but it heads in 20 seconds very significantly. So yeah, you were definitely stressing out your aerobic systems for sure, but that doesn't take away your ability to extract and to ventilate, which is essentially what you do and what we measure. So I don't think that so that's, I think, the reason why a 30-second, like the Wingate, doesn't give you the number. It needs to be a profound more that 30 seconds add on to have that number in place. Again, the Wingate is also only on the Wingate bike, so it's only the muscle versus the leg versus also a trunk versus upper extremities. So I think you have to kind of go away about aerobic. It is a full out test when you kind of creating a huge demand on any energy system available, and any energy system available will go through the max, some very rapidly, some with some delay, but eventually in the 1 minute, every single system is being maxed out.
Well, thank you for clarifying that. And just a reminder to our audience, we have about 10 minutes left. So any questions you have, please do not put them in the chat. Please put them in the Q&A function at the bottom of your screen. Sorry, next question. What limitations are there interpreting NIRS signals in older/clinical populations? This is just in the context the submitter is asking, they're just thinking about body composition.
Oh, no, cool question. Absolutely. So one of the downside of NIRS itself is its penetration in the skin and the dermis and also subcutaneous, and therefore also, of course, muscle layer. So you have to go by 1.5 centimeters or so. A little bit depends on what specific sensor you use. So if you have patients who have a very significant subcutaneous fat layer, then you will not able to reach the muscle itself. You're only measuring the kind of the microcirculation in the subcutaneous tissue layer. There are ways of doing it differently. I have a couple of approaches here. One of the things I always do, I use a lot of ultrasound based also on my imaging background. But I use a lot of ultrasound to define specifically what is the location with the least amount of subcutaneous fat. You can measure that very easily. If you want to kind of assess someone, and the leg, and I think the VL, vascularis, is if someone is kind of obese or has a more pronounced kind of subcutaneous fat layer, go more to the calf. The calf is an interesting kind of muscle, mainly looking at the medialis side of the gastroc, which shows a significantly lower subcutaneous fat layer. Another part is, and that's what we're doing right now, is there's another way of kind of using as a kind of a central way of oxygenation, not specifically to the muscle itself, but kind of looking at the mixed venous pit, and that's with the use of the temporalis. So the temporalis is an interesting muscle itself. There's tons of other stuff that we do also here from validation perspective, but it's a kind of a canary in the mine regarding CRF. It's a muscle that changes very rapidly, and is a good kind of a proxy of your overall metabolic health. What we see is, and that's kind of the good thing about the temporalis, there's almost no subcutaneous fat layer. Regardless if you have, or if you're obese or even morbid obese, you'll always be able to assess the temporalis, also within the device. And we saw that we are going more, again, there's a lot of complications coming up, but we saw that the derivative of the extraction ratio on the temporalis has also a correlation with the oxygen EV-diff as a kind of a centralized way of looking at the extraction ratios during an exercise test. But that's always the issue with subcutaneous fat versus NIRS. Yeah.
Well, thank you for clarifying that. Another question, did you get an understanding of the percentage difference in walking versus air bike in the step test?
Yeah, I think it's always interesting. I think we did a comparison. I don't think you should compare those two, because there are completely different kind of modalities, and you're asking a different thing of a patient. With the 6 mist, we kind of saying to the patient exactly what he needs to do. With the 6 minute walk, we kind of let him free. The only thing we say, you need to do, try to see how much distance you can make in 6 minutes. So we kind of defining himself in what he's going to do. Does he start fast? Does he start slow? Whatever. I think if you're still doing the 6 minute walk in your clinic, the add-on of physiological data as a kind of a 6 minute walk plus is always there. There's always an interesting stuff that we see. O2 pulse is interesting, potentially see how they were able to respond and augment. What we see right now is that when you're using, and that was kind of interesting going back, and that's still one of the articles that we're going to publish, is if you use the equations. So if you're looking at distance itself, in the equations of the distance versus V to max is always kind of weird. For me in my population, I see, and we see a lot of long COVID post-ICU patients. We don't know see that relations very well. And I think just the ability to have insight in how people respond specifically to a demand that you're giving them is already in essence very interesting to do. So if you have the ability to kind of add on those sensors in maintaining your 6 minute walk, I would always argue, yes, do that. There's always a benefit in having those specific data and have a better insight how people will do that. Yeah.
This is a two-part question. Following up from the others, a sporting/healthy population, how do your peak values correspond from the 1 minute assessment to a regular GXT? Have you measured this?
Yeah, that's exactly our validation, what we did, and it correlated well. Only right now I'm going the other route. We're going to see if it's the 1 minute allowed test also feasible in the clinical population. And I think you need to make sure or see that if an athlete goes all out on the airbag for 1 minute, there's definitely a different modality or intensity when a heart failure patient would do the 1 minute allowed, right? We know, and clinicians who or CPETs, people who done CPET in heart failure patients, when you have a VO2 max of 12 versus a VO2 max of 57 or so, that test itself will be significantly different in regard to how people respond to the test. They are not allowed. A heart failure patient will not crumble or will not puke or will not sweat at all, where a D1 athlete will go all the way out and will definitely be on his knees and potentially puke and sweat all over the place. So there's a lot of specific limitations in a patient who need to be addressed, but you can do very well doing that specific CPETs, but which you also can address doing a 1 minute allowed. Again, still as anecdotal, we are right now looking at some data, and it's still kind of me going the way from feasibility and less risk. If my approach was for the 6 missed, it needs to be a test done easily in any given place and with the benefit of being safe. Also, the benefit of the 1 minute allowed is it is very safe. The chance of fall is almost nihil because you're sitting and you also have your hands in front of you when you're reaching out. And it is, of course, a more profound recruitment of all muscle. So there could be a different kind of signaling that we do not measure right now.
And really fast, just accompanying that question about competitive athletes, can you use the data from the shorter test to try to predict training zones for elite athletes?
Yeah, now, good point. I think that's definitely what you cannot do, unfortunately. So the zones, if you want to do a true zone test, you need to have more profound, larger blocks. A little bit depends what you want to do. If you want to do some specific metabolic profiling, I would argue for at least 1.5 minutes or even 3 minutes if possible, to really see some steady states there. So you need to do a more ramp protocol. The 1 minute allows will not give you any potentially thresholds at VT1, VT2 at all. No, because you're already up in the in zone 5 at the end, whatever. Yeah.
Thank you for answering that. And this will be our final question because we are about at time. The submitter says, I completely agree VO2 max is the most important risk biomarker ahead of cholesterol, blood pressure, smoking, etc. All should be measured. However, the 9-panel plot gives you much more info about organ limitation. And do you work with the Wasserman 9-panel plot at all? Do you integrate that at all?
Yeah, the Wasserman plots I did not show them because we didn't have the time for it, but our Wasserman plots we always on the end as an addendum to the report itself. I wanted to kind of create the big gray area in assessment of CPETs. If you're interested in the Wasserman, in the 9-panel Wasserman plots, you can still do that. That's fine. But they also want to kind if you are a physician in a perioperative assessment clinic, you're only interested in 1 or 2 things. You don't want to have to go through the full nitty-gritty. You're seeing 120 patients a day. If you want to go to the Wasserman plots 120 times a day, that's at least 10 minutes a patient. Not going to work out. That's exactly the reason why CPETs are not done that rapidly, because this is a lot of time, not only doing it, reporting it, but also from a physician perspective to understand it. So you need to make sure it's a very understandable, easy metric that only defines specifically what the physician is needed to know. Of course, you can do the full shabam of the end titles and potentially do also some broadcast stuff. But sometimes we really need to make sure that the focus is there, and then we have a good, I think, understanding and start of using this specific modality in a much larger scale.
Well, thank you for that and for answering all the questions. I'd like to thank you for your wonderful presentation, your insights, going through the kind of avalanche of questions that we received. We want to thank VO2 Master for their support of our mission to provide scientific education free of cost. And of course, I want to thank the audience for attending today. Before you sign off, we hope that you will take a few minutes to complete a short survey just about the session and then other topics related to exercise and cardiovascular physiology that you want us to cover in the future. All right, have a good day, everyone. Take care.